Jesse Kaplan, and I'm pleased to be your moderator for this webinar on navigating the risks of prescribing opioids for chronic pain in the COVID-19 era. In this webinar, we will be exploring the legal, medical, and compliance challenges for individual practitioners and healthcare organizations in treating chronic pain and prescribing opioids, particularly during this COVID-19 pandemic. We'll be looking at these challenges from three different perspectives. From a physician who's an expert in opioid prescribing standard of care, from a licensed clinical social worker who has designed and conducted hundreds of physician competency evaluations and training programs, and from my perspective as an attorney who has represented healthcare organizations and healthcare regulatory agencies. We hope through this webinar that you will gain a better understanding of the issues that healthcare practitioners face in treating patients with chronic pain, and the unique challenges for opioid prescribers during the COVID pandemic. We also hope you'll gain a better understanding of the legal and regulatory risks that practitioners and healthcare organizations face if they don't get this prescribing and this treatment right. You'll learn how practitioners and healthcare organizations can assess the risks, both the risk to their patients and their regulatory and compliance risk. And you'll be given recommendations on how individual practitioners and their healthcare organizations can improve their chronic pain treatment of their patients and reduce the risk from opioid prescribing. We hope to have time at the end of the webinar for questions from the audience. To send us a question, you can use the Q&A feature at the bottom of your screen. So let me introduce our presenters. First, we have Dr. Amy Fogelman. Amy is board certified in internal medicine, is a practicing physician, and is the founder of MedLaw Consulting. Amy is an expert in opioid prescribing practices. Among other achievements, Amy led a multidisciplinary group of addiction experts and hospital leaders to create a first-of-its-kind hospital-wide primary care pain policy at Massachusetts General Hospital in Boston. Amy was also appointed to serve as a member of the Special Commission to study medication-assisted treatment for opioid use disorder in Massachusetts. Amy has been an instructor at Harvard Medical School and has assessed the opioid prescribing practices of scores of physicians and physician extenders, identifying gaps in their standard of care and recommending strategies for improvement. Welcome, Amy. Next, Deb Waugh. Deb is a licensed clinical social worker and is the Director of Assessment Services for Affiliated Monitors. Deb has years of experience designing and implementing physician competency evaluations and training programs, including as the former program director for the Center for Personalized Education for Physicians, or CPEP. And she's a founder of Clinical Competence Solutions, an educational resource for healthcare practitioners. At Affiliated Monitors, Deb oversees the assessment and monitoring of physicians on behalf of licensing boards and agencies in over 40 states. And I'm Jesse Kaplan, an attorney and managing director of corporate oversight for Affiliated Monitors. Before joining Affiliated Monitors, I was the general counsel of the Massachusetts Executive Office of Health and Human Services. I've also been a partner with Epstein, Becker & Green, and I served as chief legal counsel for Fallon Community Health Plan and HMO. At Affiliated Monitors, I oversee assessment and monitoring of healthcare organizations, including hospital systems, addiction treatment facilities, and health insurers. So we're going to first set the stage with respect to what are the legal and regulatory risks when prescribing opioids to treat chronic pain, and I'm going to do that. So policymakers in the healthcare industry are trying to address the opioid crisis in different ways. One is to focus on the prescribing of opioids with the goal of significantly reducing the number of people who are prescribed opioids and become addicted, or who divert legally prescribed drugs. Healthcare providers who engage in inappropriate opioid prescribing are increasingly subject to discipline by professional medical boards. They face restrictions on their licenses to practice, and in certain cases have had their licenses suspended or revoked. Where patients are harmed, providers also face civil medical malpractice liability. And in the most egregious cases, providers have been prosecuted criminally, either under the Federal Controlled Substances Act or state criminal laws. There are a number of federal and state laws impacting opioid prescribing practices. Some of the more recent and significant developments include state laws limiting the quantity and dosage of opioids that can be prescribed, and requiring providers to use and check prescription drug monitoring databases, or PDMPs, before prescribing certain drugs to a patient. There are also more sophisticated guidelines for practitioners, including CDC guidelines for prescribing opioids. And these are becoming the standard of care for prescribers. Just about every state has what I mentioned, the Prescription Drug Monitoring Program, or PDMP, which is a database that tracks a patient's history of opioid prescriptions. Increasingly, states require providers to check the PDMP before prescribing opioids. By checking the PDMP, the physician can be informed whether the patient appears to have an addiction problem, maybe doctor shopping for opioid prescriptions, or maybe diverting drugs, or might be at risk for dangerous drug interactions. More and more states are also passing laws limiting the quantity or dosage of opioids prescribed. For example, in Massachusetts, where I am, they were the first state to pass such a law in 2016, and it set a 7-day limit on initial opioid prescriptions. And the CDC has guidelines, as I mentioned, that are targeted to primary care physicians treating adult patients for chronic pain. And these guidelines are designed to improve communications between providers and patients about the benefits and risks of using opioids, and ultimately to reduce opioid addiction and overdoses. According to the CDC, the three main principles behind their guidelines are: first, non-opioid therapy is preferred for chronic pain in most circumstances. Second, the lowest possible effective dosage should be prescribed. And third, clinicians should always exercise caution when prescribing opioids and should closely monitor their patients who have been prescribed opioids. The CDC then offers additional recommendations addressing each of these principles. So with this background of kind of the regulatory landscape and the legal regulatory compliance risks from improperly prescribing opioids, let's talk about the challenges of treating chronic pain and prescribing opioids during the COVID pandemic. So first, I'm going to start with a question for Dr. Fogelman. So Amy, during the COVID crisis, you've been working with other physicians and health policy experts on strategies for the medical community on how to respond to the pandemic. Could you tell us a little about who you've been working with and what you've been doing?
Hi, thanks, Jesse. Yes, so I am the Executive Director of Communications for the COVID-19 Action Coalition. We are a grassroots, bipartisan, physician-led advocacy group. We're focused on protecting public health during the COVID-19 pandemic. So we've been involved in a number of initiatives, everything from donating and delivering personal protective equipment to needy healthcare workers, to calling all the testing sites to make sure that the information was up to date, to creating guidelines, and a lot more. And if you can't tell, that is a cartoon that one of the students created of me with our COVAC logo for our Mask Up campaign. So back to you.
Sorry, little problem unmuting myself. So thank you, Amy. That's really interesting. So let me ask you this. So based on what you've been seeing, what are the challenges that patients and their physicians currently face in addressing chronic pain? And how are patients and their physicians navigating these challenges during the pandemic and in a virtual medicine environment?
Yeah, well, before I answer this, can we go to the next slide? Before I answer that question, I would be remiss if I didn't mention that there are new guidelines that were put out earlier this month by a group of prominent pain physicians from multiple specialties. It's published in Pain Medicine and also online. And it's just about best practices in pain management during the COVID pandemic. If you have not reviewed them yet, I highly recommend that you do so. We could have an entire webinar reviewing the guidelines. They're excellent. And there's several sections, including managing opioids, which are really quite pertinent. So, to answer this question, treating chronic pain is challenging in the best of times. And the pandemic definitely creates some challenges, but it also has created some opportunities. So next slide, please. I asked a group of my colleagues, I said, how's it going prescribing opioids during this time? And a lot of what I heard back was, well, it's going fine because I trust my patients. And I call that the trustworthy trap. And it's a problem because anyone can become addicted to opioids. It has nothing to do with whether or not they're trusted by their physician. So doctors can become complacent and think that their patients are not at risk for this known side effect of opioid therapy. So in reality, everybody is at risk. So this is a real problem. It's a problem during COVID and not during COVID, but I think particularly now, some doctors are getting a little bit complacent. The next thing is, there are fewer objective findings because we're relying on telehealth. And obviously, the video examination is going to be more limited. You can only see what the patient is showing you. You can't really evaluate the pupils that well. You can't smell the patient. You can do maneuvers, but it's going to be, challenging, and you're going to have to be really kind of creative about how to do that. Similarly, there's a lack of other objective evidence that you would rely on when it's not in the pandemic. So toxicology screens, you should still get them, but if your local caseload of coronavirus is really high, you may think that the risk for the patient to go to the lab and to get tested outweighs the benefit of having them tested. And so the lack of toxicology screens is a limitation. Doing something like pill counts is going to be more challenging in a virtual environment. And then obviously there are some other issues like patients losing their employer-sponsored insurance. And then also, the disparities involved in the access to telehealth. So for example, older patients may not feel comfortable using a video visit, and poorer patients may not have internet access. And this is just going to further the disparities that exist in these complicated patients. Next slide, please. But there are some opportunities that the pandemic has brought us. And for example, it's easier for some of our patients to check in by these virtual visits than actually traveling for an in-person visit. So for some patients, compliance is actually better during the pandemic. And there's more time for each visit because there's less wasted time. You're not wasting time, bringing the patient to the room and checking their vital signs, or the physician's not going to be running behind because multiple patients hit traffic, which is, believe me, the bane of every practicing physician's existence. So there's also been some relaxation of the DEA rules during the pandemic. Next slide, please. This has allowed, some better access to outpatient pain treatment virtually, as well as opioid use disorder treatment. So this slide is just showing, this is by no means comprehensive, but it just shows the timeline of some of the early major changes that were announced by the DEA during this public health emergency. So for example, on March 16th, they announced that registered practitioners can use telehealth during the pandemic for controlled substance prescriptions. Then on March 25th, they said that registrants can prescribe over state lines. That's really helpful because if you have a patient, for example, that lives in a different state than your practicing. That was a problem before this was announced. Now, caveat, check your state laws because individual state laws may vary. On March 28th, the DEA announced exceptions for the requirements of paper delivery of prescriptions for emergency oral Schedule II prescriptions. And then on March 31st, there was really a boon for opioid use disorder, meaning that authorized prescribers can provide buprenorphine to new and existing patients with opioid use disorder via the telephone, which is something that's new and hasn't been there before. So as you can see, overall, the pandemic has afforded both challenges and opportunities for chronic pain management.
Great, thanks, Amy. So those challenges that you mentioned, can translate into risk. Seems like risk for both the patients and for the physician. And even some of these opportunities, like the relaxation of the DEA guidelines, can also translate to potential risks. My next question then is for Deb. Can a medical practice or organization assess the risks from prescribing opioids for chronic pain, particularly in the COVID era, and how would they go about it? Who do you use to assess these risks, Deb?
Hi, thanks, Jesse. So definitely medical practices and organizations can evaluate these risks, and going about it, I think requires first a look at the facility itself. In the past 5 years, there have been a lot of instances in which facilities have purchased or sold individual clinics, and that can result in some inconsistencies with policies that exist. So the facility needs to really take a look at that first and foremost and make sure that all of the facilities and their outpatient clinics have a controlled substance use policy in place. That's going to be the first way to at least set the stage and mitigate risk. There needs to be a controlled substance policy that is thorough and complete. It needs to clearly reflect the facility's stance and what their expectations are for practitioners to consider when they're prescribing. It needs to acknowledge federal requirements and guidelines. Also, some states have specific rules and regs that need to be adhered to. And then also, if the facility wants practitioners to look at a specific guideline and reference that for their prescribing, such as those put out by the CDC, that needs to be stated in the policy and procedures. Definitely the facility should have a controlled substance agreement that practitioners use to discuss with their patients. And the facility is going to also get some bonus points if they have what's called a patient termination policy, which is a policy that guides those unfortunate incidents when a patient no longer should receive controlled substances by the facility and the practitioner because of the way that they're managing their medication. And definitely that patient termination policy needs to be in place and addressed in the controlled substance agreement so that everybody's on board and understands the ramifications in advance of an incident happening. Next slide, please. So, it's very important, obviously, for the facility to be sure that they're communicating this information to all of the prescribers and taking a look at how they're doing that and when they're doing it. It's really easy to set up your policy and disseminate it and have an in-service on day one about it and get everybody's buy-in. But then things change, and maybe you've got new practitioners coming on board, and you have to make sure they are getting that same in-service into the policy. You also need to make sure that with changes such as all the COVID rules and regulation changes that Amy was mentioning, that those also are included. So you have to update the policies, and again, make sure you're distributing them and make sure that your practitioners understand the expectations. So that's one of the biggest issues in looking at the risk. First, making sure that inside the facility, your risk is mitigated because you've set this up. Next slide, please. The next thing is looking at the practitioner or a group of practitioners. If you've done your due diligence with your policies and now you want to dig a little deeper, maybe there's a concern that it seems like there's problems with a lot of your practitioners, but you're not really sure what's going on, or maybe it's an individual. The who in having somebody look at the prescribers is somebody that needs to be an objective, ideally a physician who has a lot of understanding of controlled substance management as well as of chronic pain. And somebody that would be somebody that might have retired from the facility a long time ago, so could be seen as a neutral, or it could be somebody that's located in another state, but part of the same general clinic and facility group. The next thing that the facility needs to decide is, what are they looking at? Are they wanting to consider the patients that are receiving long-term pain management and specific medications that are being prescribed? Are they looking at the highest morphine milligram equivalent, or MME, that's being prescribed and identifying the pool that way? Or they could be considering just doing a review based on specialty. A lot of specialties that prescribe medication for controlled substances for chronic pain on a regular basis are primary care providers, interventional anesthesiologists, and physiatrists or physical medicine and rehab doctors. Before really digging too deep into the actual charts themselves to see what's going on with patient care, the auditor might want to take a look at trends and determine who's prescribing the most. Are there the same medications or medication combinations popping up over and over again? Trying to kind of just get an understanding of what is happening with the specific practitioner prescribers, as well as what's happening with the patients. From there, the auditor should really look at the documentation that the prescriber is using to support the oversight of controlled substance medication use. When Amy and Jesse and I did an overview of a number of practitioners prescribing, we were surprised to notice that there were many patients who had shifted physicians or advanced level nurse practitioners or PAs for no reason other than just logistics and practitioners moving, things like that. The problem was when the new practitioner received that information and that patient, the practitioner did not always go back and do a little bit of due diligence, really looking at the diagnosis and whether it was wholly supported, looking at what medications had been used and non-controlled substances, as well as considering whether non-medication management, such as counseling, physical therapy, meditation, acupuncture, those kinds of things have been used. So those are really good components that the auditor should take a look at when they're reviewing the chart. And honestly, all of this is very tough. Physicians are in such a busy situation right now. So being able to do that, extra due diligence in reviewing a diagnosis sometimes can get away from the practitioner. And it's not that they're trying to overlook their responsibilities. They just need a reminder and need to figure out how to set that time to do that. Now, during COVID, if a physician's medications were initiated during this time, the auditor might want to look and see whether or not on-site appointments have occurred, if it's possible to do that in their state and given the patient's individual risk factors. So that's like one more little piece that needs to be considered. I'm ready for you to take back the helm, Jesse.
Okay, well, thank you, Deb. That's really helpful. And so my next question is going to be for Amy. So in your work assessing provider treatment of chronic pain and the prescribing of opioids, what are the most common or significant issues you've seen? How can they be addressed? What are the procedures or protocols that clinical practices should have in place?
Thanks, Jesse. So, yeah, I mean, I think Deb hit this a little bit, and I'll just talk about it a little bit more from the clinical perspective. When she was talking about, I call this the autopilot problem, the issue she was discussing about the patient who was maybe the opioid was started by a different clinician in the past, and before the current understanding of the risks of opioids, and it's just been renewed over and over and over again by whoever inherited the patient through the years. And the problem with that is that oftentimes it lacks a specific diagnosis. So, for example, a very common diagnosis that we would see during the review is, quote, chronic pain. And that's problematic because obviously, the treatment of gout would be different than a treatment of chronic migraines. Both of those are examples of chronic pain. Neither of those would really warrant opioids, but my point is just that chronic pain is certainly not specific to warrant a high-risk treatment. There's also times when a diagnosis would be for a condition that actually opioids aren't even recommended, like fibromyalgia. So this can be fixed by stopping and reassessing. And so the clinician should have a visit with the patient to just talk about this issue. Why is the patient on opioids? What was the workup? Is there a safer, better, more effective treatment for this condition? And many times when you do this review, you're going to find there's actually a better treatment for the condition than the opioids. If they were started on the opioids 10 years ago, there may not have been the same types of treatments for that condition that there are now. So a regular review should be part of any chronic pain patient's care plan. It's just really important. Another common problem that we would see was risky drug combinations. So opioids alone carry the risk of respiratory depression. And when you add certain medications to them, that increases the risk. So the common problem medications I see prescribed are benzodiazepines. These have been shown to increase the risk of overdose, increase the risk of all-cause mortality, and clinicians should avoid prescribing opioids and benzodiazepines concurrently whenever possible. So a lot of times there are better choices. So For example, if someone is on the benzodiazepine for being anxious, have you considered talk therapy? Have you considered a medicine like an SSRI to get to the underlying, cause of the anxiety, like Zoloft or sertraline? And this would require a slow wean down. Don't just stop the benzodiazepine. It also requires a partnership with the patient. But I will tell you that it can be incredibly effective. I've actually had patients thank me when they're finally off the alprazolam or Xanax because their anxiety is so much better controlled. Another, risky combination would be other types of sedative hypnotics like sleeping pills or muscle relaxants. And another type of medication would be gabapentin or Neurontin and pregabalin or Lyrica, which have been shown in recent studies to increase sedation and mortality. So those are, concerning. There are other medication combinations that create different types of risks. So for example, blood thinners. If the patient is on an opioid, they're going to be a little bit more tired. They may be at an increased risk of falls. And then you add that to a blood thinner, that increases their risk of having a really serious hemorrhage. And there may be no other treatment options for the patient, but at the very least, the patient should be informed about this risk. And many times when I would do the review, I would find there was no evidence in the chart that this had ever been discussed with the patient. And so a good informed consent document should have this in it. So the next problem that I would see would be problems with toxicology screens. So toxicology screens are very important. They are objective piece of evidence for this high-risk medication, and we don't have a lot of objective pieces of evidence. It can tell you if the patient is actually taking the medication. It can tell you if the patient is taking other substances. So it's really important. The problems that I have seen with the tox screens are either that the clinician is not checking it, or they're checking it, but they're not interpreting it. So it's like as if it's a checklist that they went through, like, oh yeah, the tox screen was checked, but then they never actually looked to see what it showed. You wouldn't send a CBC and not interpret the results. And the same thing should be the same for toxicology screens. So this is particularly concerning when there's a concerning result. And the two types of concerning results that are seen are either the presence of illicit substances or non-prescribed prescriptions. So let me explain this first. I'm gonna explain the first one. So you think you're the only doctor for this patient. You think you're the only prescriber. You think you know everything that they're on, and you think the only thing they're on is oxycodone. And you send the toxicology screen, and it comes back, and there's a benzodiazepine in there. And you're like, that's odd. Why is that there? So either the patient is getting the benzodiazepine from the illicit market, or there's another prescriber that you're not aware of. But either of those situations should not be ignored. So if they're, if they have substance use disorder, they should be referred. So you need to screen them for that. If there's another prescriber, they'll say, oh, hey, doctor, I've been seeing Dr. Jones for years. I've been on this medicine for years. Yeah, she's across the state. That's why it's not showing up in the, the prescription monitoring site, but everything's good. There is still the risk of those two medications. And so you should alert the patient of the risk, but you should also really have a conversation with the other prescriber and maybe consider the fact that opioids may not be warranted if they need to continue on the benzo. So that's one problem with toxicology screening. The other one is the absence of the prescribed med. So I'll tell you how this happens. So the urine comes back, it's clean, and nobody realizes that it's missing the oxycodone that the patient is supposed to be taking. So that is a huge problem. that clean tox screen that you don't appreciate, that the oxycodone that you're prescribing is not detected. This can be subtle because there are different things that can go into account for this. It can have to do with the amount, the dose that you're on, how frequent the patient, takes it. But you should really discuss a toxicologist about these results. But if the tox screen should have been positive for the oxycodone and it's not, that suggests that the patient is doing something else with the oxycodone that you're prescribing, and they're probably diverting it. And if you're concerned that they're diverting it, you need to stop prescribing and, refer it to a diversion protocol. So you really should be following the pain guidelines for best practices. And that includes checking the tox screen, but that also includes interpreting it each and every time. Next problem, not prescribing naloxone or Narcan. This is like a no-brainer. The CDC recommends it for certain risk factors and when the morphine equivalents are high. I personally recommend it for every opioid prescription. I just think there should be no stigma associated with it. What if a pet got into your, opioid? What if your grandchild or a guest in your home? I just think it's like a seatbelt. It's there when you need it. And if you don't need it, it doesn't harm anyone. This is a little bit challenging in the COVID era when some people are alone and so there's nobody that's available to administer the Narcan, but it's still, I think that's not an excuse not to prescribe it. And then the last one, which is probably the most concerning, is ignoring evidence of misuse. So like as Deb said, like 99.9% of doctors, they are really well-meaning and they're trying to do their best. But when this happens, it's really concerning. So an example would be if the patient's on really high doses of opioids and they end up admitted to the hospital intubated and for respiratory depression, there's never really a cause that's found. And so that needs to be suspicious that the patient, overdosed on the opioid. And then you really need to consider that patient should be weaned, the opioid should be weaned. The second one would be, it's not quite as dramatic, but, the frequent early refills. My dog ate my medicines, it fell down the sink, somebody stole it. Because if you keep giving them their early refills, if you're believing them every time, if they're not being straightforward with you, this can result in stockpiling of meds. And then, the frequent dose escalations, that can either be a sign that there's worsening of the underlying pain condition, or it can be a sign of opioid use disorder. And I just really want to make it clear that there's nothing like bad about it. It is just very important to consider opioid use disorder as a known side effect of chronic opioids or even acute opioids. It should not be stigma associated with referring these patients for specialized treatment when the side effect occurs. There's really effective treatment and there's no reason it shouldn't happen. Back to you.
Thank you, Amy. Really, really interesting and really helpful. So, Deb, hearing what Amy says, are there remediation strategies and resources for physicians or practices that are physicians or the practices that are actually deficient in how they address chronic pain or how they're prescribing opioid treatment? Are there strategies and resources for these practices and these physicians, and to help them document their medical decision making?
Yeah, there definitely are remediation strategies and resources, Jesse. And when I was thinking about this and what resources there are for both practitioners as well as for the facility where they're working, it seems like there's two considerations that we need to think about now. The first one would be what resources and tools are there prior to the COVID. And then the next one would be how have practices changed related to us living in a pandemic? And before going to kind of blaming the practitioner and citing fault with that individual, it's again really, really important to look at what they understand and how are they adapting in this new world. Obviously, for all of us, the pandemic is overwhelming and incredibly stressful. And physicians and advanced practice practitioners are all overwhelmed even more so with their current roles in taking care of patients. So I'm not giving them an excuse, but I want to just make sure that everybody remembers that. We have a luxury, many of us, of sitting back and looking at a computer and working all day in our homes that practitioners don't have. And so they're out there having to think about whether or not they've got any exposure to the COVID, as well as trying to address the regular patient encounter issues and also patients with COVID. It's really overwhelming. As Amy was saying, when telemedicine is being done, doing the physical examination of a patient is totally different. And one of the things that I was realizing is that there are tools that might be good for all facilities to provide their practitioners to make it a little bit easier to kind of think about, okay, what are these new considerations that we can put into place when we're having our practitioners consider or refill controlled substance medication. So by giving some sort of a tool to them, then you're making sure that they're kind of thinking through this a little differently than they used to. I think it'd be a great idea for facilities or practitioners to identify a couple new guidelines. Yes, we're losing some ways of doing physical exams, and as Amy was saying, smelling the patient, doing some of the physical manipulations. And so you have to look at, well, what can we rely on now? And with the patient presentation, you can take a look at whether or not they got dressed for the appointment, if they are physically, online looking at you. Do their clothes have stains on them? Or, and look like they've been wearing the same thing for days and days or not? What's their hygiene look like? Did the patient make an attempt to do their hair? Does it look like they've got gunk in their teeth? And what was their presentation to the practitioner in the past? Another good thing for the checklist would be to have information about whether to ask the patient to stand up if they're able. Look at how they're standing up. Is it a fluid motion? Are they jittery? Are they shaking at all? Same thing, ask them to extend their arm and look for tremors in their hands. That might be something that the practitioner can pick up, even though it's a virtual interview. And then think about other visual appearance considerations and what might be different with this patient than before in the non-COVID environment. Then looking at the patient's speech, is it slurred? Is it slow? Are they completing their sentences? And is that how they used to do it before? And then the last thing would be, is the patient repeating themselves? Do they seem like they understand the practitioner's questions? How has that changed, or is it the same? Those are going to be some very important ways that the practitioners can now supplement their evaluations. when they're not able to always see the patient in person. The other areas are going to be more related to just checking in and seeing how the patient's doing emotionally, because patients who are at risk for dependence and abuse of medication frequently are struggling to cope. Oh my gosh, so again, I can't emphasize how important it is to think about how the patient is coping with COVID, and having the practitioner, adding that on the list for the practitioner to think about is a really good, straightforward question. I think that the majority of individuals are very comfortable sharing this information with the, with their friends, with their physicians, or practitioners, definitely. And then if there's time, checking to see if the patient's experienced any significant changes, like employment and income, which are huge, health insurance. Have they experienced any friends or family members dying? Because that's been obviously happening and touching many of us. Reminding the practitioner to also consider, what does the patient's locus of control seem like? And that means, does the patient seem like they feel like they have any control over their situation? Or are they feeling really like everybody is imposing what to do and how to do it on them? Again, it increases their risk for taking more medication than they might usually take. So those things need to be considered. The last items that I'd be wanting to put on a checklist for the practitioner would be looking at substance use. There's been all sorts of studies talking about the increase in alcohol purchases during the pandemic, and some of that was because at one point some states were planning to stop selling alcohol, and that did a run on the market. But also it does appear that many people are using alcohol more often now than they might have before. So obviously drinking alcohol or taking recreational drugs at the same time as you're medicating with controlled substances, it's a risk for all sorts of problems, as well as increased dependence and addiction. And it's important for the facility to make sure that their practitioners thinking about that again, and asking those questions again about how substances are being used. Checking to see whether or not there's any significant changes in the amount that is being used, the frequency of being used, when is that happening? Is it at the same time as taking the controlled substance or not? And reminding the practitioners that they need to double check on the size of the glass. I've heard jokes where, the patient tells the practitioner, oh, I'm only having one glass of whiskey a day. And so the practitioners got that sense of relief, don't have to deal with this issue, everything's good. Meanwhile, the family is in the background saying, oh my gosh, but did they say that the glass is the size of a 7-Eleven Super Gulp? So, you can't assume. You've got to ask those questions. So those are important things that can serve as very good resources for the facility to provide to the practitioner before going to the practitioner and saying, boy, it seems like your patient care management with regard to prescribing controlled substances is a problem. With that, then you get to that place where you're looking at what are the problems? What's the physician, next slide please, what's the physician or practitioner dealing with, and how can you address it? And before I go there, I'm sorry, I meant to mention that there are some resources that patients can continue to take advantage of online now. Social work, psychology, counselors, those are being covered by insurance doing audio calls as well as telehealth. So people can reach out and get that support that they need. And then the other things, there's still AA has figured out how to provide an anonymous environment for individuals who need that service as well, so that that's not dropping out of somebody's experience. Next slide, please. So you've got all these great systems in place for practitioners, and still you've got an individual that is concerning in the way that they're prescribing. One of the most important things to do is going back, making sure the practitioner is aware of and understands the policies and procedures in place at your facility. Next, making sure that the practitioner takes a look at the state rules and regs that are guiding controlled substance prescribing. These are kind of no-brainers, as Amy was saying, but I'm amazed at how many practitioners just have not looked at them due to time, due to, so many things on their plate. So, make sure that that recommendation's there. And if there's still issues, consider referring the practitioner to use educational resources, either webinars online or reading, self-study. And the next 2 pages will provide a number of resources that are available for physicians and advanced nurse practitioners and PAs. If you've gone through that stepwise process and there's still problems, then it might be time to consider whether the knowledge problem or the decision-making problem that's evidenced by the practitioner needs one-on-one focus. Maybe consider getting a mentor at the facility to work with the provider and to talk about what the provider knows and how that's being put into patient care, or get somebody on the outside to do objective monitoring, where they focus the clinical updates and understanding and then talk with the physician or provider about what's being learned, how is it being used in patient care management. The last thing I want to mention, because it's something that I forget frequently and is very important, is communication. I do not think that many of our practitioners were taught how to communicate with patients about in challenging situations. So in saying, I'm not going to refill your medication and here's why, or, that's not the best treatment for you and I want you to go to PT. It's real hard. None of us like confrontation. And, when you've got a patient who really wants something, it's very hard not to give it to them. So the last 2 slides that follow have some resources that are very useful in guiding practitioners and facilities to make sure that they're staying current on rules and regs. I'm always also available if anybody has any specific questions about what else might be available. So back to you, Jesse.
Great, thanks, Deb. Really, really helpful. And for all listeners, we do plan to make this PowerPoint available and to send it out to all the people who registered for this webinar. And in particular, those last 2 slides that Deb put together of resources, I think should be really helpful to all of you. So I've got a couple of minutes left, and what I'm going to do is I'm just going to wrap it up. I mean, what I hear, and I'm sure what you all hear, is that even for the most well-intentioned physicians, treating chronic pain, diagnosing, treating chronic pain, prescribing opioids is complex as an understatement. And there are many risks to the patients and to the physician and the practice if they don't get it right. So the question then becomes, and as a lawyer who represents organizations and regulators, the big question is kind of the known unknown, which is even if I assume these physicians are all well-meaning and good at what they do, I don't know whether they've been able to follow all the different guidelines, the standards of care, the evolving standards of care, and utilize all the tools that they should be utilizing when they're diagnosing and treating chronic pain, and especially prescribing opioids. So how do you address this kind of known unknown? Deb early on mentioned about doing self-auditing of your physicians, but that's not always feasible for organizations. And so what an organization or a clinical practice can do is you can hire a firm like Affiliated Monitors, and engage them to do to assess the opioid prescribing program and practices of the physician or of the physician practice. Firms like ours, we use experienced physicians like Dr. Fogelman, who are experts in pain management and opioid prescribing. And what they'll do is they'll work with us to assess the program, review patient charts, and make recommendations for improvement. We also will develop prescribing policies for clinical practices, and we can provide education and coaching for prescribers to help them improve their standard of care. In the end, the goal of having an independent firm do what we call a proactive assessment is to identify areas for improved practices, provide clear guidance, and recommend relevant medical education to help physicians provide better and safer treatments for their patients, while also protecting them and their organizations from legal risks. So that ends our presentation, and I think we have time for a question or two. I don't know if we have any from the audience, but I have a question that I'd like to ask both Amy and Deb, and that is, in April, I read that Health Affairs published an article titled, "Once the Coronavirus Pandemic Subsides, the Opioid Epidemic Will Rage." And recent reports have indicated a surge in opioid prescriptions during this crisis. What are your thoughts on the opioid epidemic post the COVID crisis, and what do you see as contributing factors? And I guess I'll start with you, Deb, if you don't mind.
Contributing factors to the opioid crisis, I think so many of the issues are related just to the socioeconomic and cultural difficulties that we're having right now in our country. So I think that is further spurring it, and it's really hard to know how to address it because we haven't gotten out of the pandemic yet. So Amy, I'm turfing to you.
Yeah, I mean, you mentioned that the alcohol sales are up. Overdoses are up in many states. And so, I think that addiction risks are high due to social isolation, due to increased anxiety and depression and lack of coping, due to boredom. All of the things that can happen can. And, as I said before, you can't use Narcan if you're alone. And so somebody who is quarantining alone may die alone, unfortunately, if they overdose. So I think that the loosening of some of the DEA restrictions to allow for opioid use treatment virtually is a good start, but you know, there's challenges with that. You know, a lot of addiction treatment centers have had to close because they're just not being funded right now. So I think that this is a big problem, Jesse, and it does concern me.
Okay, well, thank you both, Deb and Amy. We're at the end of our hour. Thank everyone for joining us for this webinar. As I mentioned, we are going to, the plan is to send out both a recording of the webinar as well as the PowerPoint presentation to all registrants. I think we'll also make it available on the Affiliated Monitor website. And stay tuned and stay safe. Thank you, everybody.